Hello, my name is Dr. Jean Connors. I'm a hematology attending at Brigham and Women's Hospital, Dana-Farber Cancer Institute, and Harvard Medical School. I'm going to be presenting coagulopathy in critical care settings. This is my disclosure slide. My agenda for this presentation will include a brief review of hemostasis, a review of the laboratory testing for coagulation, and a general review of management and available hemostatic products, including in the setting of DIC, disseminated intravascular coagulation, and anticoagulant reversal. The key point that should be made for anybody treating coagulopathy is that you should treat the bleeding patient and not numbers, not lab values. An elevated PT or PTT does not mandate treatment if there is no bleeding. The requirements for hemostasis are basically three areas. Primary hemostasis, which involve platelets and von Willebrand factor, and to a lesser degree, the vessel wall. Secondary hemostasis, which involves the soluble coagulation factors. There's activation of these coagulation factors by both intrinsic and extrinsic mechanisms, and the pathways have different initiation points that end in a common pathway. This is the coagulation cascade. Platelets will supply calcium and a phospholipid surface to anchor and orient these coagulation factors, as well as procoagulant roles of their own. Secondary hemostasis also involves thrombin generation and ultimately formation of cross-linked fibrin monomers. Tertiary hemostasis involves clot retraction and cross-linking of these fibrin monomers by factor 13. Now, ideally, these processes for hemostasis occur at normal body temperature, normal pH, and normal serum calcium values. Whenever you are approaching a bleeding patient, you should start with a history and try to determine whether this is an acquired or inherited bleeding disorder. For many patients in the ICU setting, the bleeding disorder or bleeding manifestations will clearly be acquired either due to the disease process itself or to treatments that are given to the patient which exacerbate bleeding. The physical exam is important with regard to both type and location of bleeding. So diffuse oozing is very different from bleeding from a distinct surgical site. Ecchymoses and petechiae suggest platelet dysfunction, whereas a large incision or trauma-related bleeding is a combination of coagulation factors and platelet abnormalities. The basic laboratory tests that should be performed in the bleeding patient or patient with a suspected coagulopathy include a CBC and review of the peripheral smear, particularly looking for microangiopathic processes, PT or prothrombin time, a PTT, which is partial thromboplastin time, fibrinogen, and D-dimer values. Now, this very busy slide is an overview of the coagulation cascade with various coagulation tests and the factors and pieces of the coagulation cascade that are represented in the specific tests. I like to start at the bottom of the coagulation cascade and work backwards with regard to the types of tests. So ultimately, activation of coagulation either through the intrinsic pathway or the extrinsic pathway results in generation of thrombin. Thrombin cleaves fibrinogen to fibrin monomers. These are cross-linked by factor 13, resulting in a cross-linked fibrin polymer. The thrombin time simply measures whether or not the fibrinogen is viable and can participate in clotting, or whether there is perhaps an inhibitor that inhibits thrombin, or a dysfibrinogenemia, as can be seen in acquired liver disease, where fibrinogen cannot be cleaved to fibrin monomers. The PT test basically measures factor 7. The common factors of 10, 5, 2, which is also prothrombin, and fibrinogen in the common pathway are similar in both the PTT and the PT. So the PT is basically measuring the extrinsic pathway and the amount of factor VII available to participate in coagulation, whereas the APTT is dependent on factors 12, 11, 9, and 8. If there are abnormalities in any of these factors, the PTT will be prolonged. For the common pathway factors, again, 10, 5, 2, and fibrinogen, both the PT and PTT can be elevated in the setting of abnormalities or deficiencies of these factors. The ACT, the activated clotting time, is a whole blood clotting assay that basically looks at how long it takes for this entire process, plus platelets, plus red cells, plus white cells, to clot in the test tube. So if you have a patient who has a high PT but a normal PTT, there are two, and you're looking at whether it's an inherited or an acquired disorder. For patients who appear to have had lifelong bleeding deficiencies and an abnormal PT but normal PTT, the only inherited deficiency in this situation can be that of factor VII deficiency. For patients who have acquired elevation in the PT but a normal PTT, vitamin K deficiency, an early vitamin K deficiency, warfarin use, a factor VII inhibitor, or early liver disease, such as an early shock liver, the PT will elevate long before the PTT in these situations. If you have a normal PT but an elevated PTT, the range of inherited factor deficiencies, congenital factor deficiencies, is much larger. For an elevated PTT in somebody who appears to have an inherited bleeding disorder, factors 8, factor 9, factor 11, and factor 12 can result in an elevated PTT with a normal PT. It should be noted that factor 12 deficiency does not result in a clinical bleeding phenotype, but only an elevated PTT, whereas von Willebrand disease moderate to severe von Willebrand disease can result in an elevated PTT because von Willebrand factor chaperones factor 8 and protects it from degradation. So low von Willebrand factor will result in low factor 8 activity and an abnormal PTT. There are rare inherited disorders of high molecular weight kininogen and prekallikrein that also can contribute to an elevated PTT in a normal PT. For acquired elevated PTT and normal PT, there can be specific factor inhibitors, such as acquired factor 8 inhibitor or less rarely inhibitors to factor 9 or other specific factors. Antiphospholipid antibodies can result in an elevated PTT. However, they do not result in a bleeding diathesis. And heparins, even small amounts of heparin present in the tube or possibly present in a catheter, such as a dialysis catheter line, or central access catheter, such as a portacath, can result in a significantly elevated PTT. If both PT and PTT are elevated, you can have rare inherited disorders such as dysfibrinogenemia, hypofibrinogenemia, and the even more rare deficiencies of thrombin, factor V, or factor X. It's more common in the ICU setting for patients to have an acquired abnormality, and this can be the result of significant hemodilution, an inhibitor of thrombin, factor V, or factor X, as can be seen in situations of patients with tumors, particularly amyloid and other paraproteins. Patients who are supratherapeutic on heparin, warfarin, or DTIs, the direct thrombin inhibitors, can have an elevation in both the PT and the PTT. And of course, liver disease, most of the coagulation factors are synthesized in the liver, and so significant liver disease can result in elevated PT and PTT. Consumptive coagulopathies such as DAIC, or even in cavernous hemangiomas such as Kasabach-Merritt syndrome, can result in an elevated PT and PTT due to consumption of fibrinogen and the coagulation factors. So in order to evaluate these abnormal coagulation tests for an elevated PT, A specific factor VII activity level can be sent, and a mixing study can be performed on the PT if the factor VII level is normal. If a patient has an elevated PTT only, the first step would be to do a mixing study where you take patient plasma and mix it with normal control plasma in a 50-50 or 1-to-1 ratio. If the PTT corrects to normal, that suggests that the patient is missing a factor. They have a factor deficiency, and at that point, it's important to do specific factor levels for factors in the intrinsic arm of the coagulation cascade, such as factor 8, 9, and 11. If there is no correction in the PTT upon adding normal plasma, then this suggests that there's an inhibitor to coagulation, such as a lupus anticoagulant or a specific factor inhibitor, or even a drug such as previously mentioned heparin or bivalirudin. If both PT and PTT are elevated, it is important to assess fibrinogen as well as the common pathway factors such as 10 and 5 and D-dimer, and particularly looking for a drug effect in this situation. Now, moving on to how to manage coagulopathy. The first goal is to actually establish the diagnosis and try to understand where the coagulopathy arises from. Supportive care in many situations for patients in the ICU is the most important factor in terms of trying to achieve a good outcome. The severity of bleeding and the need for procedures will affect your treatment decisions. If the PT and PTT are elevated and the platelet count is minimally low, but there is no clinical bleeding, there is no need to treat this patient to normalize the numbers if there's no bleeding. In general, fibrinogen should be greater than 100 or 200, depending on what is going on. A platelet count should be greater than 20 to 30,000 per microliter. As I've just discussed, you really need to assess, is there a need for a, quote, normal PTT or PT, or can the patient be okay with their minimally elevated PT and PTT? Replacement products that are available include plasma, variably known as fresh frozen plasma, FFP, or TP, which is thawed plasma. Plasma contains all the clotting and anti-clotting factors present in normal healthy people at normal plasma concentration. So if you take a 70 kilogram person, that person has 2.8 liters of plasma. A normal PT and a normal PTT require factor levels that are generally of 30% activity or higher. Each bag of plasma has approximately 250 mLs of plasma. The acceptable range is 180 to 300. So if you are starting at less than 1% activity for coagulation factors, if you want to replace a 70 kilogram person's entire plasma volume to achieve minimal coagulation factor levels, you will need to give 4 to 6 bags of FFP, or approximately 20 mils per kilogram, which roughly translates to 1,000 to 1,500 mils of plasma. This is a huge volume load for many patients. And again, the use of FFP or thawed plasma to correct minimal elevations in particularly PT-INR is not endorsed by a number of societies. Cryoprecipitate is the cold insoluble fraction proteins that is left as you thaw plasma. It contains just 3 products: fibrinogen, von Willebrand factor with the factor 8 that's bound to von Willebrand factor, and factor 13. It's obtained from 1 unit of whole blood. It contains the high molecular weight proteins that are cold insoluble as you start thawing FFP. These proteins are resuspended in 15 mils of plasma, which is equivalent to 1 unit of cryo. Each unit of cryo has minimum factor 8 and fibrinogen levels per AABB standards. And at different institutions, an order of cryo contains usually 10 units of cryo, Where I work at Brigham and Women's Hospital, we split the 10 units of cryo into 2 bags, each containing a pool of 5 donors. It's important to check with your local blood bank to determine what one order of cryoprecipitate contains at your institution. FFP and cryo have some adverse effects associated with them and with their infusion. For FFP, it's certainly volume and infusion time. To infuse 4 to 6 bags of FFP in an awake patient through a peripheral line can take hours. Patients can have allergy to plasma proteins that are non-self and resulting in mild itching and hives, all the way to anaphylaxis. TRALI, or transfusion-related acute lung injury, felt to be due to alloimmunization to HLA antigens in the U.S., is now avoided as female donors who become alloimmunized during pregnancy are excluded from sources of plasma, so that in the U.S. only male donors are used to make FFP or cryo. TACO, or transfusion-associated circulatory overload, can easily happen in patients who receive massive amounts of plasma. For both FFP and cryo, it's important that it be ABO type compatible because FFP contains all the allo-ABO antibodies in various ABO type blood donors, as well as cryo is suspended in the small amount of FFP, similarly containing allo antibodies. FFP and cryo are not pasteurized or solvent detergent treated products. These products are available. The pathogenicity of FFP and cryo is pretty minimal these days, with good separation of white cells, which are usually responsible for transmitting disease. Donors are carefully screened, but then nonetheless, there is concern for pathogenicity of FFP and cryo. Fibrinogen concentrate is available and was approved as the trade name Riastap, approved by the FDA for use in the United States in 2009. It is a concentrate made from pooled plasma. It is heat treated and lyophilized and comes in a dry powder form that is reconstituted with a very small volume of usually water or normal saline. The label indication is for hypofibrinogenemic patients or afibrinogenemic patients, but not for dysfibrinogenemia or patients with congenital dysfibrinogenemia, as there is a bit of a concern for thrombogenicity. Patients who are hypo or afibrinogenemic are somewhat rare. I see these patients in my outpatient clinic setting, but these indications are the only FDA-approved indications. There is certainly off-label use of fibrinogen concentrate in acquired hypofibrinogenemia, such as post-TPA, systemic use of TPA for stroke thrombolysis, obstetric hemorrhage, including postpartum hemorrhage, postoperative hemorrhage, and intraoperative use, as well as trauma-associated hemorrhage. Fibrinogen concentrate has been increasingly used in Europe due to concerns for Creutzfeldt-Jakob disease from untreated plasma. PCC are prothrombin complex concentrates. These contain factors 2, factor 7, factor 9, and factor 10. The vitamin K-dependent coagulation factors. They are available in much smaller volume than FFP or cryo. Similar to fibrinogen concentrate, these are lyophilized and supplied as dry powder form with a small volume diluent. There are data for efficacy for use of PCC in warfarin reversal. There is questionable data about efficacy with reversal of rivaroxaban, but there has been no response with dabigatran. The specific reversal of direct oral anticoagulants will be covered by me towards the end of this presentation. At this point, we do not endorse use of PCC for reversal of rivaroxaban. The 4-factor prothrombin complex concentrate contains adequate or equal amounts of all of the factors 2, 7, 9, and 10, as well as protein S and protein C. It is dosed based on factor 9 activity, and the package insert has a nice table for warfarin reversal and the use of variable dosing depending on what the PT-INR is. The standard dosing is usually somewhere between 20 to 50 international units per kilogram. The only available 4-factor PCC in the United States, the brand name is Kcentra. It was approved for use in the United States in April 2013. It should be noted that it contains a very small amount of heparin present in the processing of the plasma concentrate, and it is strongly advised that it should not be used in patients who have heparin-induced thrombocytopenia. Now, a 3-factor prothrombin complex concentrate exists, such as Profil 9. This 3-factor prothrombin concentrate complex concentrate contains significantly lower amounts of factor 7 compared to the other factor levels. So if you are using a 3-factor PCC to reverse warfarin, you need to give some FFP up front to supply a source of factor 7 as well as vitamin K. FEBA is a prothrombin complex concentrate, but it is an activated prothrombin complex concentrate. FEBA actually stands for Factor VIII Inhibitor Bypassing Activity. It was initially developed long before recombinant technology existed for hemophilia A patients who had developed inhibitors to Factor VIII. It contains factors 2, 9, and 10, and it contains activated factor 7, just like recombinant factor 7A or Novo-7. It is an activated prothrombin complex concentrate. There is debate about whether or not it is less thrombotic than recombinant 7A. Recombinant activated 7A, the trade name, and the only available product is Novo-7. It had been in the past the favored antidote for all bleeding, despite lack of data for use. We have cardiothoracic surgeons who love to use this to get off bypass. However, the cost of this product and lack of data for efficacy in many situations has caused many institutions to limit its use. There is a concern for risk of thrombosis with using an activated product, as with FEBA. There was a fantastic review of all of off-label studies by Levi et al. In the New England Journal of Medicine in 2010, which demonstrated that basically older patients were at most risk for having thrombotic events with an odds ratio of 2.4 to 3 after getting recombinant factor 7A for bleeding manifestations for the most part. Switching more now to disease states. DIC, or disseminated intravascular coagulation. What causes DIC? There are a number of different factors that contribute to development of DIC. In many situations, it's the increased expression or exposure of tissue factor, such as the sites of trauma, tissue necrosis, or burns, where factor 7 in the vascular endothelium, in the matrix, is exposed and can activate factor 7. Stimulated monocytes or endothelial cells stimulated by endotoxin, cell wall polysaccharides, or immune complexes can also upregulate expression of tissue factor. Also is seen in endothelial sloughing from acidosis. Thrombogenic phospholipids are clearly related to activation of coagulation, particularly in obstetric disorders such as abruptio placentae, eclampsia, and amniotic fluid embolism. Intravascular hemolysis, such as seen in transfusion reactions with intravascular hemolysis, such as in major ABO incompatibility, or infections resulting in intravascular hemolysis, can also promote the release of thrombogenic phospholipids and acidic fluid. Patients who have DIC can present either with bleeding or with thrombosis. And sometimes if it's low-grade compensated DIC, such as in the setting of somebody with mucin-producing adenocarcinoma, such as pancreatic cancer, there may be neither bleeding or thrombosis. Patients who do present with bleeding, the bleeding often is in the setting of patients who have underlying liver disease, surgical wounds, or those who actually develop Waterhouse-Friderichsen syndrome, which can be a manifestation of DIC. Patients who develop microvascular thrombosis can develop thrombosis particularly in the lungs, the kidneys, the liver, the heart, and the brain, basically the major organ systems. Purpura fulminans can manifest as gangrene of the digits or skin necrosis due to rapid consumption of protein C and protein S in the setting of DIC. How to manage DIC? The primary overwhelming need is to identify and treat the underlying condition that's driving the DIC. And in the process of identifying and treating the underlying condition, supportive care is the mainstay of management of DIC. If the underlying condition is rapidly reversible, you can watch and wait it out if the patient is not having significant active bleeding. You can use FFP, cryoprecipitate, and platelets as needed. Again, please treat the bleeding patient and not just numbers. Ideally, fibrinogen is greater than 100. Platelets are greater than 20 to 30,000. If the patient is bleeding, these thresholds need to be set at a higher level. Many attempts have been made and many studies have been performed and many products have been looked at to try to stop the microvascular thrombosis that occurs in the setting of DIC. You can consider heparin, TPA, urokinase. The role for the use of these products is definitely more established in patients who have chronic compensated DIC than acute DIC. You can try low dose 4 to 5 units per kilogram of IV unfractionated heparin. This works extremely well. You can see normalization of coagulation parameters. You can see the fibrinogen increase. However, the use of heparin or any of these products has definitively been shown not to affect mortality. There is no benefit to outcome of the patient by using these products. In the setting of DIC and controlling bleeding, if you cannot use FFP due to volume or cryo, you can use Riastap as a source of fibrinogen concentrate, or even Kcentra if volume is a problem. Kcentra will supply 2, 7, 9, 10 proteins S and protein C, remembering that it has a small amount of heparin. There is a question about whether the natural anticoagulant products can diminish the effects of DIC and improve outcomes. However, no mortality benefits have been shown in any large phase 3 studies or even phase 2 studies that are larger than pilot studies for the use of antithrombin, activated protein C, or recombinant thrombomodulin. TFPI is under investigation, but so far studies have not been fruitful. Other investigational agents are still being developed, and as yet large trials have not been performed. We switch gears from DIC to anticoagulant-related bleeding, and how do we manage anticoagulant-related bleeding? I think everybody is familiar with management of heparin-related bleeding. If a patient is on unfractionated heparin or has had a large dose of unfractionated heparin, protamine can be used to reverse all of the unfractionated heparin. For those patients being treated with low molecular weight heparin, Protamine will reverse roughly 60 to 80% of the low molecular weight heparin activity. It will not fully reverse low molecular weight heparin. For fondaparinux, the synthetic pentasaccharide that results in activation of antithrombin, there is no specific reversal agent. Many people have tried recombinant 7A and published their reports, but the data are extremely limited. For warfarin, we will discuss warfarin reversal in greater detail. Vitamin K, fresh frozen plasma, and prothrombin complex concentrates can be used to reverse warfarin depending on the urgency and degree of bleeding. For parenteral direct thrombin inhibitors such as IV bivalirudin or IV argatroban, the only reversal agent available is that of time. Bivalirudin has a half-life of 25 minutes, argatroban 45 minutes in patients with normal renal or liver function. For the new oral anticoagulants or direct oral anticoagulants, idarosizumab is available for life-threatening dabigatran-related bleeding or need for urgent surgery. 4-factor PCC has been tried, and we will discuss both of these further along in this presentation. Other antidotes for reversal of the new oral anticoagulants are in development. So for a patient who has the need for vitamin K antagonist or warfarin reversal, the options are basically to replace the missing factors. You can accomplish this by giving vitamin K, which allows the liver to synthesize the vitamin K dependent factors so that they can be activated, but this can take time. This can take easily 12, if not 24 hours or longer to completely normalize the INR after administration of vitamin K. Fresh frozen plasma, but as we discussed, this can be volume prohibitive. And prothrombin complex concentrates, non-activated versus activated, and we will discuss this. The first question, however, is do you really need to reverse the warfarin or VKA? Is this patient bleeding? If the patient is not bleeding and the INR is in the range of 4 to 10, you can simply hold warfarin with no need to do anything except continue to monitor the INR until it returns to the targeted range. If the INR is greater than 10, it's suggested that warfarin be held and that you can judiciously use vitamin K at low doses to bring the INR down to the target range. Keep in mind that when you give vitamin K, it can be harder to reinitiate warfarin in these patients. A great study was published by Ravi Sarodi in Circulation in 2013, comparing the use of 4-factor PCC, the non-activated 4-factor PCC, versus FFP in 202 patients who presented with major bleeding. They were randomized to 4-factor PCC versus FFP, and the endpoints were INR less than 1.3 at 1/2 hour or 0.5 hours after administration, as well as hemostatic efficacy at 24 hours. And you can see from this graph right here on the right-hand side of the slide, when you look at the fraction without INR corrected and you look at time since start of study product infusion, patients who received 4-factor PCC, as demonstrated in the red, had a dramatic drop in INR. 62% of patients treated with 4-factor PCC experienced an INR less than 1.3 after the first dose of 4-factor PCC, compared to roughly 10% of patients treated with FFP. Now, this translated to roughly the same endpoint at 24 hours, but based on the severity of bleeding and location of bleeding, immediate reversal may be significantly more beneficial to patients than prolonged reversal. It depends on the degree of bleeding and the site of bleeding. Efficacy outcomes of other events are very difficult to measure in these bleeding populations with number of comorbidities. At this point in time in the United States, 4-factor PCC, available only as Kcentra, is the standard of care for emergent reversal of warfarin-related bleeding. For DOAC antidotes, idarosizumab, as I mentioned, Praxbind or idarosizumab is a humanized monoclonal antibody fragment that binds to dabigatran. It has a 300-fold higher affinity for dabigatran than dabigatran has for thrombin, so it binds dabigatran and basically clears it out of the circulation to reverse dabigatran-related inhibition of coagulation. This was FDA approved for use in October 2015. It is a one dose for all patients who present with dabigatran-associated bleeding, or for those patients who require life-threatening who require urgent or emergent surgery to fix life-threatening problems. Every patient exposed to dabigatran with these indications will get a 5-gram IV bolus dose. Reverse AD was the real-world observational study of idarosizumab in bleeding patients or requiring emergency surgery, on which the FDA based approval. Group A was uncontrolled bleeding. Group B were those patients who required emergency surgery. They did get a total of 5 grams of idarosizumab infused as 2 back-to-back 2.5-gram boluses. The, quote, real-world study demonstrated that idarosizumab reversed up to the 99th percentile of dabigatran levels as measured in the RELY trial, and met efficacy endpoints of decreasing the dilute thrombin time, a measurement that you can see is elevated in those patients who in the real world presented after taking dabigatran for some interval of time and having bleeding or requiring urgent surgery. The group A were those required urgent surgery. Here is the mean dilute thrombin time, and after administration of idarosizumab, you can see that it reverts to below the upper limit of the normal assay for dilute thrombin time. Similarly, Eckarine clotting time, the mean Eckarine clotting time was here with this wide splay as seen in patients who present in the real world. And in all of the patients after administration of idarosizumab, you have the Eckarine clotting time reverting to the normal range. The primary endpoint, again, maximal reversal of dabigatran based on lab tests within 4 hours of administration, was achieved in 100% of the patients who were studied in the Reverse AD study. Normal hemostasis was seen in Group A in over 90% of those patients undergoing emergency surgery. And in those patients who presented with bleeding, hemostasis was felt to be achieved within 11 hours. This endpoint is somewhat difficult to measure. Now, there were a number of deaths in this study, but half of the deaths were felt to be due to the underlying condition or to the bleed itself, and not related to the idarosizumab. There were 5 thrombotic events in these patients. However, these were in patients in whom anticoagulation was not restarted. There's continued support of this study with a goal to accrue 300 patients. The next antidote to the direct oral anticoagulants or new anticoagulants is andexanet alpha. Andexanet targets factor Xa inhibitors, which include apixaban, edoxaban, and rivaroxaban. This is fascinating technology in that recombinant technology was used to manufacture a decoy factor Xa molecule that has a mutation in the catalytic site so that it cannot participate in anticoagulation, and it's missing this GLA domain so it cannot bind to other coagulation factors. It is felt to be a universal factor Xa inhibitor antidote and can reverse the anticoagulation effects of low molecular weight heparins, as well as apixaban, edoxaban, and rivaroxaban. There was a recent release of the interim analysis of the real-world study in August 2016. It has not yet been approved by the FDA for use. This is a graph of the efficacy of andexanet in the ANNEXA-R study in normal, healthy volunteer people who were given rivaroxaban to steady state and then were treated with a bolus of andexanet versus placebo versus a 2-hour-long infusion. And you can see that in the red line, that patients who were treated or volunteers who had taken rivaroxaban had dramatic and rapid drop in rivaroxaban plasma factor, anti-factor 10A activity when treated with the andexanet versus infusion with bolus with placebo. However, what I do not show is that if patients received only the bolus, there was a rapid rebound in anticoagulant activity, so that a 2-hour continuous infusion of andexanet is required to suppress the anticoagulant effect of rivaroxaban. The curve looks very similar for apixaban. At 4 hours after initiation of the bolus, the plasma concentration or the plasma activity of rivaroxaban reverts to where it would be had there been normal decay of rivaroxaban. So currently, andexanet is being studied in a phase 3b4, quote, real-world study in patients who have active major bleeding who are taking apixaban, rivaroxaban, edoxaban, or enoxaparin. And just 2 weeks ago, after I was asked to revise these slides, there's an update to the dosing, which we can supply in a slide added at the end as an addendum. Patients who are on apixaban or rivaroxaban, but more than 7 hours before, received a different dose than those patients who were on enoxaparin or received or took rivaroxaban within 7 hours of presentation, as rivaroxaban and enoxaparin required a higher dose than for those patients taking apixaban. Again, this study is in patients who have active major bleeding and not for patients who are requiring surgery. Patients were treated with a bolus and an IV infusion as demonstrated here. The results of this study, as I mentioned, were published in August 2016. Again, a real-world study, and you can see, similar to the study in human volunteers, that the anti-factor 10A activity with the baseline here for patients who took rivaroxaban or apixaban in the graph below, with the average activity level here prolonged above normal, that once the bolus was completed, we had prompt decrease in anti-factor 10A activity in almost all of the patients, with a few outliers, in those patients treated with rivaroxaban versus all of the patients treated with apixaban, which then, after the 2-hour infusion, there was a bump up in the anticoagulant activity of either rivaroxaban or apixaban, but andexanet was able to suppress the anticoagulant activity during the bolus and the 2-hour infusion. In these bleeding patients who presented in the real world, no matter what medication, gender, site of bleeding, or age range, there was at least 75% efficacy for hemostasis, and over 75% of patients achieved excellent or good hemostasis. The last antidote that I want to talk about that's in development is something called siraparantag, which is a reversal agent for all anticoagulants. It is in the early stages of development. It's a fascinating, very small cationic molecule that binds through non-covalent bonds to anticoagulants. It has been shown to cause a dose-dependent decrease in the whole blood clotting time following edoxaban in healthy volunteers, and this is being actively investigated now. So when we have these antidotes available to us to reverse these new drugs, how should these agents be used? At this point in time, with very limited data, those patients who are taking one of the direct oral anticoagulants and have life-threatening bleeding, such as intracranial hemorrhage, bleeding in a critical organ, or massive hemorrhage, or bleeding in the setting of delayed renal clearance or overdose, certainly the use of the FDA-approved idarosizumab for patients taking dabigatran is indicated, or for those patients who require emergency surgery. However, for those patients who have been taking dabigatran or hopefully a factor Xa inhibitors such as apixaban, edoxaban, or rivaroxaban, and andexanet is approved, we advise not to use these simply to reverse anticoagulation for patients who have need elective surgery or surgery that can be delayed, but someone simply forgot to tell them not to take the anticoagulant, or for those patients who have elevated coagulation tests but no bleeding, or bleeding that can be managed with routine supportive measures. There are still a lot of unknowns about these reversal agents that need to be understood more clearly for routine use in patients outside of the category who have life-threatening events. So in summary, coagulation abnormalities are frequently seen in the ICU and are usually acquired as a result of underlying disease processes. The treatment of the primary disorder is often sufficient to restore normal coagulation factor levels, although transfusion support with appropriate blood products and factor concentrates may be required. Specific reversal agents for anticoagulants are available, but improvement in outcomes have not yet been demonstrated. Moving on to question one. Question one, a 72-year-old man with a past medical history of hypertension, coronary artery disease, and congestive heart failure is admitted to the ICU with hematemesis. His hematocrit is 25%. It was previously documented to be 39% 4 months ago. His systolic blood pressure is 90. His heart rate is 120. His INR is 9.2. He is on warfarin for atrial fibrillation without a history of prior thromboembolic events. He just finished a course of trimethoprim sulfamethoxazole for urinary tract infection. He took warfarin last night. In addition to red cell support and EGD, you plan to manage the elevated INR with the following plan. A, hold warfarin and observe. He has finished trimethoprim sulfamethoxazole and INR will drift down. B, give vitamin K 1 milligram oral dose. C, give FFP at 20 mils per kilogram or 6 bags. D, give 4-factor prothrombin complex concentrate at 50 units per kilogram of factor IX activity and 10 milligrams of vitamin K. Or E, give recombinant activated factor 7A. For question one, the correct answer is D, give 4-factor prothrombin complex concentrate at 50 units per kilo. This patient has significant hematocrit drop and is hemodynamically unstable. He requires rapid reversal of warfarin to decrease and prevent further bleeding. Holding warfarin or giving low dose of oral vitamin K are insufficient. In addition to the lengthy administration time, the volume overload of approximately 1,500 mils of plasma may be difficult to tolerate in this patient with a history of congestive heart failure. Limited data support the use of recombinant 7A, and given age and history of coronary artery disease, there is concern for prothrombotic effects. 4-factor PCC is the most appropriate treatment in this patient. Question two. An 85-year-old woman is admitted at 11 a.m. with severe abdominal pain. Evaluation and imaging are concerning for ischemic bowel. She has atrial fibrillation and is taking dabigatran 75 milligrams twice daily as her creatinine clearance is 28 mils per minute. She took dabigatran at 7 a.m. The consulting surgeon determines that surgery is needed in the next 2 hours and asks what to do about dabigatran. You suggest A, there is no need to reverse anticoagulation as she is on a reduced dose of dabigatran. B, give FFP as the INR is elevated. C, give idarucizumab 5 grams IV bolus. D, insist that surgery be delayed for 24 hours. Or E, give FEBA according to the package insert. The correct answer to this question is answer C. This elderly woman has ischemic bowel and renal insufficiency. Plasma dabigatran concentration is likely still at its peak as it has been only 4 hours since the last dose. Delaying surgery for another 24 to 48 hours is not an option given the life-threatening nature of ischemic bowel. Idarucizumab is FDA approved for this indication and should be used. Other options such as FFP or FEBA are not acceptable or not adequate to reverse the anticoagulant effects of dabigatran.